Hi, my name is Natalie Morrow and I'm a Prosthetist Orthotist with APOS Ltd. I've put together this presentation today on the orthotic management of non-diabetic ulcerations with my colleague Karen Duff. APOS is a private prosthetic and orthotic company based in Galway. We've recently moved from Kilcolgan to Oranmore. Although our main base is Galway, we have satellite clinics nationally working with different MDTs across the country. We aim to provide an excellent standard of care by assessing, manufacturing and fitting custom-made prostheses and orthoses. We have an on-site workshop in Oranmore, therefore we're able to manufacture the majority of our devices in-house. Both orthoses and prostheses are counted as Grade 1 medical devices. So, what is an orthosis? An orthosis is an externally worn device which applies forces to certain segments of the body in order to correct and control movements, as well as limiting unwanted movement and redistributing pressure. This is done through altering the magnitude and direction of forces applied. At the assessment stage, it must be determined which key orthotic goals we are trying to achieve. The key orthotic objectives are to correct or resist a deformity. Where this is not possible, we look to accommodate it. We also look to offload areas of peak pressures, protect vulnerable tissues and prevent unwanted movements. In following these key objectives, we also aim to eliminate pain where it is present. All of these are essential in preventing ulceration as well as assisting in healing of active ulcerations. To correct or resist a deformity, we first look at the level of correction which is achievable and assess which areas will be pressure tolerant or pressure sensitive to determine where to apply our corrective force system. Early intervention can be key to maintaining a normal foot alignment, especially in cases of muscle imbalance or weakness. This is important in reducing the risk of ulceration, as the more deviated a body segment is from the normal alignment, the higher the risk of skin breakdown through abnormal loading and increased pressure points. Using orthoses such as total contact insoles, which are known as TCIs, and ankle foot orthoses, which are known as AFOs, can help reduce the risk of pressure-related ulcerations. Where a deformity cannot be corrected, it must be accommodated. This is to try and prevent further progression of the deformity and reduce the risk of skin breakdown. This can be done through modular or custom footwear, TCIs and AFOs. Redistributing forces can be done in many ways dependent on the area of concern. The larger the region the force can act upon, the less force will be applied to one specific area. Through redistributing these forces, we are looking to protect vulnerable tissues and reduce risk of skin breakdown, especially in those at higher risk of ulcerations or those with reduced healing capabilities. Finally, we want to prevent unwanted movements to try to emulate the normal kinematics of the gait cycle in order to reduce the risk of skin breakdown. Musculoskeletal disorders and imbalanced muscles can lead to abnormal loading of the limb and result in increased peak pressures, which can increase the risk of skin breakdown. Just a quick run through of a few pathologies at higher risk of ulceration. The first is peripheral vascular disease, which is when the arterial supply to the limb is compromised, which results in reduced healing capabilities if ulceration did occur. Therefore, we focus on the orthotic principles of protecting and offloading from the onset to prevent ulceration. This can be done through the use of accommodative footwear, TCIs and bed resting AFOs. Patients with PVD are at higher risk of amputation. Therefore, we frequently see a crossover between prosthetic and orthotic design. In the case of partial foot amputations, these can be treated with a partial foot prosthesis or orthotic intervention such as insoles with toe fillers, sometimes used with a carbon plate, rocker soles or AFOs. Spina bifida is another condition at very high risk of ulceration. This is due to neuropathy, muscle weakness and subsequent muscle imbalance. These features can lead to abnormal loading and altered biomechanics of gait, all of which mean the skin is at very high risk of breakdown. Spina bifida patients also have reduced healing capabilities, therefore early intervention and protection of these patients is vital. This can be done through orthotic intervention using TCIs, accommodative footwear, as well as AFOs and knee ankle foot orthoses, known as CAFOs. Lastly, we're going to look at rheumatoid arthritis. Now this varies greatly in presentation, but deformity at the foot and ankle is commonly present. This includes features such as clawed or hammered toes, bunions or reduced fatty pads across the met heads. All these features increase the risk of skin breakdown through abnormal loading and increased pressure points. Therefore, accommodative and protective intervention is required. It must also be remembered when treating these patients that generally their sensation is intact. Therefore, these areas can be very painful and require significant offloading. Now, I have touched on a few different types of orthoses going through this, but now we're going to delve into a little bit more detail. Firstly, we look at foot orthoses, focusing on total contact design. TCIs are used to correct or accommodate foot positions and deformities and offload areas of peak plantar pressures through total contact. This increases the surface area for forces to be more equally distributed across the foot, assisting in healing active ulcerations and alleviating pressure in the high-risk foot. To achieve a total contact design, the device must be custom made. In designing these foot orthoses, we must look at the design and specification required and consider our material choices depending on the patient requirements. For example, we need to assess where higher density material may be used to load pressure onto the pressure tolerant areas while significantly offloading the pressure sensitive areas or areas of concern. These areas of concern can then be backfilled in a softer material to provide further offloading again. Design features such as met bars and domes, sinks and donuts must also be considered and positioned where required to provide suitable offloading and pressure relief. As well as redistributing pressure and offloading specific areas, we must look at the biomechanical objectives the insoles aim to achieve. Using wedging or skies can improve the gait pattern and patient's mobility. TCIs can also be used to accommodate fixed deformities of the foot, and when prescribing a foot orthosis, it must be carefully assessed which deformities are fixed and which are flexible. On to footwear. There are several different types of footwear. To begin with, we're just going to touch on offloading temporary shoes, which are designed to specifically offload specific regions of the foot. These are rarely used as a definitive intervention and are generally used in the interim whilst custom orthoses are being manufactured. Stock footwear, things like podiatrist shoes or doctor comfort shoes, are generally used as a step up from off-the-shelf footwear. These provide a wide and deep alternative and it can accommodate small foot deformities nicely. When stock footwear are no longer suitable, the patient will then move on to modular footwear. Modular footwear comes in a wide array of laths which accommodate many different foot types and deformities. These laths can then be adapted further and be customised to the patient's needs. You can customise them by adding different modifications such as bunion pockets, increasing instep circumferences, increasing toe box steps, as the patient requires. Custom footwear is used when the foot deformities are more than can be accommodated by modular footwear and suitable modifications. Custom footwear is made to specific patient measures and casts are taken in order for the footwear manufacturer to create a lath specifically used for that patient. Typical features of orthotic footwear include wide and deep toe boxes, seamless uppers, soft leather or neoprene uppers, and butterfly toe puffs. Orthotic footwear should also have enough room to accommodate a TCI. They also must have a secure lace or velcro fastening. Slip-on shoes are never acceptable as they increase the risk of friction and shear. Material choice and spec is very important and individual patient considerations must be taken into account when prescribing footwear, whether this be a specific lining that's more durable or maybe a waterproof lining, or whether a harder lightweight sole is required depending on the patient needs. We must fully delve into the patient's history and requirements before prescribing footwear. So moving on from footwear, we're going to look specifically at sole modifications. Rocker soles can be very effective in helping to offload specific ulceration sites and aid progression in gait. These modifications can be made to stock, modular or custom shoes and can also be added to the patient's own high street footwear when suitable. There are many different types of rockers that can be added to footwear as can be seen in this illustration, but it is very important to be specific about the placement of a rocker in order to achieve maximal offloading. For example, to offload the met heads, the rocker is generally placed 5 mm behind the met heads. In order for a rocker sole to be effective, the sole must be rigid. Another sole modification which can be very useful is the addition of a flare. This increases the width of the sole and can be added either medially, laterally or either side. The larger the flare, the larger the lever arm, and the resultant force being applied on the shoe and the patient is increased. Medial flares are used to resist pronatory movement, lateral flares are used to resist supination, and flares on either side of the heel are used to increase the overall stability. Moving on to an increased level of support, we look at ankle-foot orthoses. There are many different designs of standard AFOs, including rigid, posterior leaf spring or articulated, and several others. Regardless of design principles, there are certain key objectives which standard AFOs aim to meet. These include normalising gait deviations and improving mobility, restricting abnormal movements at the foot and ankle, redistributing pressure, and slowing or preventing deformities in at-risk groups. There are both off-the-shelf and custom options available, and the decision of which to use is dependent on the severity of deviation and the level of support required. Night and resting AFOs encompass the same basic principles as mentioned. However, they are not used for ambulation and focus more on contracture management and controlling deformities. There are also specific AFOs designed for bed rest and offloading the heel. These are used to reduce pressure-related heel injuries. There are two versions, one of which allows for ambulation, known as a PRAFO, and the other which is purely for bed rest. These are both commonly off-the-shelf devices. Increasing the level of control again, we look at the weight-bearing AFO, also known as a PTB AFO. These are specifically designed to provide offloading to the plantar aspect of the foot by suspending the limb from pressure-tolerant areas around the knees, such as patella tendon, popliteal fossa, and tibial flares. This device increases the surface area through which pressure is distributed and shifts weight proximally onto the shin, as well as restricting unwanted movement at the foot and ankle. It can be used with or without a TCI and is frequently used with orthotic footwear and rocker soles. As well as being used to offload plantar ulcerations, this can also be used to offload and control severe foot deformities and aid in the offloading of non-union fractures. A PTB AFO is also seen as a slightly more cosmetic alternative to a crow walker, which is what we are now going to discuss. The Charcot restraint orthotic walker, also known as a crow, is most commonly used for the offloading of the Charcot foot. Now, first of all, just to state that although Charcot foot is most commonly seen in patients with diabetes, it can be seen in a variety of other conditions. A crow is a custom-made bivalve device designed to provide total contact to the plantar aspect of the foot, ankle and calf. It is made with a custom TCI and shifts weights proximally onto the shin whilst restricting triplanar motion of the foot and ankle. It is used as a weight-bearing device and has an external rocker sole built onto it. This is not just used for Charcot foot, but can also be used in offloading severe foot deformities, ulcerations and non-union fractures. So this is a brief overview of the orthotics which can be used in the healing and management of non-diabetic ulcers, but I would like to state that the principle of offloading a non-diabetic ulcer is very similar to that of offloading a diabetic ulcer. The main thing I would like to finish with is the importance of working as an MDT to treat these patients. As I said at the beginning, APOS has many MDT clinics across the country, but one which I would like to highlight is the monthly clinic ran with the Podiatry Team of CHO3. The collaborative clinic ensures the patient receives the highest standard of care and that all aspects of their treatment and the plan going forward is taken into consideration. This helps us to identify high-risk patients and how to prioritise their needs. Joint clinics is something we strongly advocate for at APOS as we feel it provides a gold standard of care to the patient. Now, obviously with COVID, joint clinics and clinics in general have posed a few new issues. However, we are working through these with the proper protocols and procedures, and as an essential healthcare service, we are still providing clinics to high-risk patients. Thank you all very much for listening, and I will be happy to answer any of your questions at the end.